This is Andrew Watson, Associate Professor of Medicine Cardiology at David Geffen School of Medicine, and this is part 2 of a lecture on Duchenne muscular dystrophy cardiomyopathy. First part, I talked about some cardiac anatomy and introduced the case of a 44-year-old with Becker muscular dystrophy who's coming in to clinic because of increased shortness of breath, difficulty breathing with exertion, and lower extremity edema. I'm going to talk a little bit more about the adrenergic response to decreased cardiac output. And in addition to the release of norepinephrine by adrenergic neurons to the actual left ventricular myocardium, there's also a systemic, sort of a neurohormonal effect of the activation by the baroreceptors and the baroreceptors on the aortic arch. And that is to stimulate nerves that innervate the adrenal medulla. And that's shown here, where these nerves actually innervate, release acetylcholine, and cause the chromaffin cells of the adrenal medulla to release epinephrine and some norepinephrine into the blood vessels. So it's actually circulating through the blood and can act distally, similar to the way hormones do. This upper figure shows what I showed you previously, which is that the sympathetic nerves can actually innervate the heart as well as other organs to cause increased heart rate and increased contractility. It's also the case that released epinephrine will stimulate beta receptors on the surface of cardiac myocytes and increase contractility and stimulate beta-1 receptors, just like the norepinephrine does. So there's two mechanisms by which the adrenergic response is stimulated. And so this acts not only on the heart, but it also stimulates alpha-1 receptors in blood vessels, the smooth muscle cells of blood vessels. And just to remind you, the features of different types of blood vessels, there are large arteries, which have quite a bit of elastin fibers as well as connective tissue, and have quite a bit of smooth muscle cells as well. But it's really the arterioles, shown here, that have a disproportionately large amount of smooth muscle cells. So they're very responsive to the effects of epinephrine peripherally. So when epinephrine is released, it causes contraction of the smooth muscle cells and vasoconstriction of the blood vessels, which actually increases the resistance to forward flow. This is a good adaptive response if your blood pressure is low. So if you're bleeding and you have an adrenergic response because the stimulation, the stretching of the baroreceptors in the carotid arteries and the aortic arch have decreased, that response of vasoconstriction to maintain blood pressure is actually a good adaptive thing to occur. But in the setting of congestive heart failure, as we'll see, that may turn into be a maladaptive response. And just to remind you, capillaries essentially are essentially just endothelial cells without any smooth muscle, and then veins have a very small amount of smooth muscle associated with them, and there is a little bit of venoconstriction in response to epinephrine release. And this just shows you both norepinephrine and epinephrine can cause the smooth muscles in arterioles to contract, to decrease the luminal size of the blood vessel and increase blood pressure, maintain blood pressure, but also increase systemic vascular resistance, or the resistance of forward blood flow. And if you think back to part 1, where you saw the echocardiogram of the patient with Becker muscular dystrophy and the decreased contractility of the heart, and that a lot of the blood was moving backwards through the mitral valve, and there was quite a bit of mitral regurgitation. If the epinephrine that's released causes vasoconstriction, it's going to be even harder for the blood to be pumped forward through the aortic valve to the systemic circulation. So because of increased resistance to forward flow, there's going to be even more backward flow. So even though this is, through evolution, is considered an adaptive response, it's maladaptive in the setting of congestive heart failure. So let's review the cardiovascular effects of the sympathetic nervous system. And at the sinoatrial node, it increases the rate of depolarization to threshold, therefore increases the heart rate. In the atrioventricular node, it increases excitability and decreases that delay at the AV node. So the movement of electrical activity going from the atria to the ventricle, instead of sort of moving slowly, it stimulates it and makes it move very, very quick. So the atria and ventricles are moving nearly simultaneously. At the level of the ventricle, it increases excitability of the ventricle. It hastens conduction through the bundle of His and the Purkinje cells so that the electrical activity gets to the heart muscles, the individual muscles, quicker. It also increases contractility of the atrial muscle and strengthens contraction, so it pushes blood down into the ventricles quicker. The ventricular muscle itself, it increases contractility and strengthens contraction, and it does that through the molecular mechanisms that were described through the activation of protein kinases. There's stimulation of epinephrine release from the adrenal medulla that indirectly causes arterioles to constrict through the release of the epinephrine from the adrenal gland. And even veins, there is some smooth muscle cells on veins, as I mentioned, so there's increased venous return, which increases the strength of contraction through the Frank-Starling mechanism of stretching the heart muscle out and increasing end diastolic volume. I want to mention that there's different classifications of cardiomyopathies. Cardiomyopathy, cardio refers to the heart, myo refers to the muscle of the heart, and pathies just means the disease of. So we're dealing with heart muscle disease. And this shows the relative proportion of the left ventricle, the thickness of the left ventricular muscle, the size of the left atrium relative to the left ventricle, and then the aorta here. And these are normal proportions. In dilated cardiomyopathy, so this is very descriptive or occurs in the setting of either Duchenne muscular dystrophy or Becker muscular dystrophy. You can see how large the left ventricle is now, very dilated. The heart muscle isn't much thicker or thinner, it's about the same. But because the pressure within the heart is increased, you can see that the left atrium, which is normally quite small, has actually enlarged quite a bit. And that's all because of the resistance to and the backup of pressure, because the heart's not pushing a lot of blood forward. And in many cases, as I mentioned previously, there can be regurgitation where the blood moves backwards through the mitral valve back into the left atrium. There's also hypertrophic cardiomyopathy, in which the heart muscle is extremely thick. This can be because of long-standing high blood pressure. It can also be because of a problem with the aortic valve. If the valve doesn't open very well, there's resistance to forward flow, and the heart gets hypertrophy just because of increased strength required to pump blood out of the heart. And then there's restrictive cardiomyopathy, usually caused by infiltrative disease, that is disease that actually gets into the heart muscle and intercalates in between the muscle cells, things like amyloid deposition. So we want to talk a little bit more about dilated cardiomyopathy. And this is where there's dilation and impairment of contractility. So the heart just doesn't squeeze very well. This results in reduced systolic function, and it can be with or without heart failure. In almost all cases, what initiates dilated cardiomyopathy is myocyte damage, that is heart muscle cell damage. And Duchenne muscular dystrophy or Becker muscular dystrophy is just one of the possible insults that can result in dilated cardiomyopathy. It could also be caused by coronary artery disease and blockages in the blood supply to the heart, damage to the heart, which causes the heart to scar and eventually to dilate. It can also be caused by a viral infection that affects the muscles, cells of the left ventricle. That can result in dilated cardiomyopathy. Lots of different causes, but the end-stage pathology tends to be the same. So here's a review question. And the question is, what are the main compensatory mechanisms in congestive heart failure? So the answer is shown here. First of all, compensatory mechanism is increased heart rate, and that's through the sympathetic response. However, even though it can be an advantage to increase the cardiac output because of increased heart rate, you also increase the chance for causing arrhythmias of the heart. And people who have congestive heart failure and increased sympathetic response are at increased risk for developing irregular heart rhythms like ventricular tachycardia, ventricular fibrillation, which in some cases can be life-threatening. Another adaptive mechanism is increased stroke volume. You remember through the effect of epinephrine and norepinephrine, the heart increases contractility and increases stroke volume with each beat of the heart. But ultimately, so that's the advantage, but the disadvantage is that eventually there could be remodeling and dilatation or dilation of the left ventricle. Another adaptive mechanism is vasoconstriction of the blood vessels, which is good for maintaining blood pressure, but a disadvantage could be the increased resistance to forward flow of blood, as I mentioned previously. Another adaptive mechanism is fluid retention. The kidneys, when there's decreased blood flow to the kidneys, the kidneys do what they're supposed to do, which they think that the blood volume is low, so they try to retain as much fluid as they can. They produce very little urine, and fluid gets retained in the body, which is good in the sense that it will help to maintain blood pressure, but overall, there's volume overload and increased venous pressure, which can cause problems like edema, which I'll talk about in a moment. What is central in the pathology of congestive heart failure is adrenergic activation of epinephrine and norepinephrine release, which is essentially toxic over a long period of time. So starting from the top, there's some myocardial insult, and that could be the lack of dystrophin protein in Duchenne and Becker muscular dystrophy. It could also be a myocardial infarction that damages the heart muscle. It could be a viral infection. It can be alcohol-induced cardiomyopathy. There's some insult which results in myocardial dysfunction. Myocardial dysfunction, when the heart is unable to contract very well, that results in increased load and reduced systemic perfusion, decreased blood flow to the body. And that, as we mentioned, stimulates cardiac adrenergic activation, release of epinephrine and norepinephrine. And that causes growth and remodeling of the heart, so the heart actually expands in size. It causes alterations in gene expression that can be deleterious, and it also causes toxicity, ischemia, and energy depletion. Growth and remodeling can result in apoptosis of the myocardial cells, so myocardial dropout, where you lose myocardial cells, which decreases the ability to contract, and also results in necrosis, or both of these are different mechanisms of cell death. The cell death just makes the myocardial dysfunction worse. You have fewer cells to do the work. And altered gene expression also contributes to myocardial dysfunction. So there's this progression of the disease which is initially adaptive with the release of epinephrine and norepinephrine, but ultimately causes toxicity of the heart, increased work of the heart with fewer resources. So that you start off with an ejection fraction of 60%, and then you have some index event that occurs. And this nice small heart with an ejection of 60% starts to dilate. And then there are compensatory mechanisms that occur that attempt to maintain contractility of the heart, like epinephrine release, but ultimately that just contributes to the pathology of cardiomyopathy, and there's more damage, ultimately resulting in a very low ejection fraction and a very dilated heart. And this occurs over years. Initially, the patient can be asymptomatic, but ultimately the patient becomes symptomatic because of decreased cardiac output, fluid retention. So let's do an experiment. How could you determine if patients with congestive heart failure have increased adrenergic tone? The answer is to measure the amount of norepinephrine levels in subjects with and without congestive heart failure. And that's actually what somebody did back in 1993. They measured the amount of norepinephrine in nanograms per minute that was found in the blood of patients with a normal ejection fraction and patients who are in congestive heart failure. And they found that the amount of norepinephrine was much higher in patients with congestive heart failure. When they looked in the arterial plasma, they found increased levels of epinephrine, norepinephrine in congestive heart failure, and even looked at the clearance of norepinephrine, and the clearance levels were much less in patients with congestive heart failure. So they were producing more norepinephrine and were taking up less norepinephrine, all in the setting of congestive heart failure. The patient with Becker muscular dystrophy had quite a bit of lower extremity edema. Let's talk a little bit about how edema occurs in the setting of congestive heart failure. Because the heart isn't pumping blood very well, the blood tends to back up. So everything proximal, that is in front of, the blood flow in front of the ventricle that's not pumping very well, the pressures start to build up. And so if you're thinking about the left ventricle, then the blood, if it's not getting pumped forward through the aorta, then that means that the pressure in the veins, the pulmonary veins, is increasing. And that pressure is transduced into the lungs. The right ventricle, if it's not contracting very well and not pushing blood into the lungs, then what happens is pressure backs up into the veins. And that pressure is transduced all the way to the arterioles of the peripheral tissue, like the legs and the arms. So what can happen when the hydrostatic pressure in the veins, the pulmonary veins or the systemic veins, increases, it starts pushing fluid out of the blood vessels into the tissue. And so the precipitating factors that can cause edema is increased hydrostatic pressure. So if it's on the right side of the heart, it results in fluid leaking into the systemic tissue. If the heart failure is on the left side of the heart, that results in fluid accumulating in the pulmonary vasculature. And in congestive heart failure, typically you'll have heart failure on both the right and the left side. So you have fluid leaking into the tissue, both in the lungs and in the peripheral tissue. Another cause of edema could be decreased plasma oncotic pressure. So there's a balance between hydrostatic pressure pushing fluid out of the blood vessels and oncotic forces, which are basically the proteins, most notably albumin, within the blood vessel that produces an oncotic force to drive the fluid back into the blood vessel. And usually there's a balance there. And if you have decreased plasma oncotic pressure, in other words, lack of production of proteins in the blood, you can also get fluid leaking out of into the tissues. Also, increased capillary permeability caused by tissue injury or medications, things like calcium channel blockers, can cause increased capillary permeability and cause fluid leaking into the tissue. And then also lymphatic obstruction. So if you have failure on the right side of the heart, that increases the venous pressure in the systemic tissue. And this shows an example of the driving forces between the arterioles here and the venules. So these are the capillaries here. And the hydrostatic force pushing fluid out of the blood vessel is about 35 millimeters of mercury at the beginning of the capillary. It's about 25 millimeters of mercury in the middle of the capillary. And then when it gets into the beginning of the venule, the pressure has decreased to approximately 18 millimeters of mercury. That is counterbalanced by the oncotic forces, which is the force pushing the fluid into the blood vessel, which is approximately 25 millimeters of mercury throughout the entire capillary. So there's an initial driving force, a net filtration pressure, or NFP, of about 10 millimeters of mercury, pushing fluid out of the beginning of the capillary, and then eventually, at the end of the capillary, bringing the fluid back in, since there's actually a negative net filtration pressure. If you, in the setting of congestive heart failure, these numbers, the pressure, the hydrostatic pressure, goes up, so that it's now on the order of 45 millimeters of mercury, 35 millimeters of mercury, and perhaps even 28 millimeters of mercury here, which is actually greater than the oncotic force bringing fluid back into the blood vessel, so that the net filtration pressure is positive throughout the entire capillary, which results in accumulation of fluid outside of the blood vessel and in the tissue. So that the fluid retention, the increased venous pressure, is what causes fluid to leak out of the blood vessels and cause edema in the peripheral tissue. The same thing happens in the pulmonary circulation. So if you have left-sided heart failure, the left side of the heart isn't pumping blood forward very well, you get pressure transduced backwards into the left atrium, into the pulmonary veins, and that pressure gets placed into the capillaries within the pulmonary circulation. That's illustrated here. Here's a small capillary that's right next to an alveolus. So the air, the oxygen, is in the alveolus and the lungs. The blood is flowing through here. And with normal hydrostatic pressure, there's just a very little bit of fluid filtration, not very much at all. This allows the oxygen in the hemoglobin of the blood to move from the oxygen in the air in the alveolus into the blood and then get delivered to systemic circulation. But when the pulmonary pressure is elevated, so the pressure in this blood vessel goes up because of fluid retention, then fluid leaks from the blood vessel into the alveolus. And this whole alveolus becomes full of water, which completely eliminates the possibility of moving oxygen onto the red blood cells. And that's why people get short of breath, because even though the blood is moving through the lungs, there's so much fluid in the alveoli that the oxygen actually can't get into the blood. You can't oxygenate the blood. And that's called pulmonary edema, which we saw on the chest x-ray of the patient who presented. So those are the major pathologies of congestive heart failure. It involves decreased cardiac output. It involves maladaptive neurohormonal responses and fluid retention. And most of the treatments for congestive heart failure, whether it's Duchenne muscular dystrophy, Becker muscular dystrophy, or some other cause, is generally the same. And I'm going to just go through those briefly. First of all, at least for Duchenne muscular dystrophy, steroids have been very promising in treating congestive heart failure, mainly focused at the inflammation that occurs because of the lack of the dystrophin protein and increased myocardial strain, inflammation. So when steroids are given to patients with Duchenne muscular dystrophy, it was found that the maintenance of the normal left ventricular ejection fraction in patients treated with steroids, either prednisone or deflazacort, 93% of them maintained a normal left ventricular ejection fraction, where only 53 maintained a normal left ventricular ejection fraction if they were not treated with prednisone. Steroids also decrease the incidence of dilated cardiomyopathy. Patients who were treated with steroids, only 32% of them developed dilated cardiomyopathy, whereas the patients who were not treated with steroids, 58% of them developed dilated cardiomyopathy. And it seems that there's increased benefit with earlier treatment of steroids, that is, before there's myocardial destruction and dysfunction. The second main component of medical therapy for congestive heart failure is the addition of angiotensin-converting enzyme inhibitors, or ACE inhibitors, or angiotensin receptor blockers, or ARBs. These medications delay progression of cardiomyopathy by blocking the angiotensin. So in addition to norepinephrine and epinephrine, angiotensin can cause myocardial damage and fibrosis. And these medications block the angiotensin-induced cardiac fibrosis. They also are basically blood pressure medications, and they dilate blood vessels. So whereas the epinephrine and norepinephrine are contributing to vasoconstriction and increasing peripheral vascular resistance, angiotensin-converting enzyme inhibitors cause vasoconstriction, vasorelaxation, vasodilatation, and decreased systemic vascular resistance, so you get better blood flow to kidneys, so they work better to keep the fluid from accumulating in the tissue. These medications also protect against renal dysfunction. Beta blockers are central, very important, the medical management of congestive heart failure. And after these lectures, it should be intuitive that beta blockers, which block the effect of epinephrine and norepinephrine on the beta-1 receptors on the myocytes, would actually be beneficial. And sure enough, beta blockers decrease the work of the heart, and they also block this neurohormonal toxicity caused by epinephrine and norepinephrine. Beta blockers such as metoprolol and carvedilol are used frequently. Another medication that's used frequently in congestive heart failure are diuretics, medicines like furosemide or torsemide. And these are medications that enhance the ability of the kidney to produce urine, and increasing the urine excretion gets rid of the fluid that would normally be retained in the setting of congestive heart failure. Once patients are treated medically, then it's a matter of monitoring their symptoms. We do this typically by talking with them, understanding how they're feeling, asking about shortness of breath, palpitations, are they having any peripheral edema. I put a question mark by diminished exertional capacity because sometimes it's difficult to know whether somebody's exertional capacity is being affected by skeletal muscle, progression of skeletal muscle disease versus cardiac involvement. Physical examination is important, looking to see if the patient is having any jugular venous distension, any evidence of pulmonary edema, peripheral edema, any new murmurs, which may be caused by the increase in mitral regurgitation in the setting of dilated cardiomyopathy, as well as ascites, which is fluid accumulation actually in the peritoneal cavity. Getting chest x-rays to look for pulmonary edema, pleural effusions, which is fluid around the lungs, not actually in the lung tissue, but around the lungs, and cardiomegaly, which is just increased heart size. We use electrocardiographic monitoring. We do EKGs as well as Holter monitoring, which is having a patient wear an EKG for an extended period of time to look to see if they're having abnormal tachycardias, any evidence of ischemia, basically not getting enough oxygen to the heart, conduction, electrical conduction abnormalities, and any life-threatening arrhythmias, such as ventricular tachycardia or ventricular fibrillation. Ultrasound, echocardiography is used frequently to monitor the heart function in patients with congestive heart failure. It gives you information about the ejection fraction, the size of the left ventricle, whether there's significant valvular regurgitation, and when the heart gets weak, you can actually develop clots on the inside of the heart. So making sure that clots are not developing, which could break off and cause stroke, is important. And ultimately, or finally, I should say, cardiac MRI is good for looking at the extent of cardiac fibrosis, the amount of scarring in the heart, secondary to the pathology of either Duchenne muscular dystrophy or ischemic cardiomyopathy in the setting of coronary artery disease. It also allows us to look at cardiac function, particularly in patients who you don't get very good images with echocardiography. So that concludes the second part of the lecture. I hope you enjoyed this lecture. I think it gives you a very good overview of using a clinical case to look at the effect of, in particular, muscular dystrophy and how it can affect the heart, the symptoms that occur with developing cardiomyopathy and congestive heart failure, and then some of the pathophysiology about how the adrenal sympathetic response can actually be maladaptive and how medications can actually prevent that sympathetic response from causing more damage, as well as the importance of using medications like furosemide to reduce fluid accumulation, decrease venous pressure to remove the possibility of edema and accumulation of fluid in the lungs and the soft tissues. Thank you.